see there is some resorption here. So the consideration to make a surgical endodontic here is correct. But in this particular case, I was lucky maybe. I did just the retreatment and the lesion did heal. So it was no needed to make the surgery. So the right answer is the answer number 3. But it is not wrong to think that I have to make a surgical endo here.
Okay, let me comment a little bit on that.
Yes, please.
I'm so happy to have you saw the lecture of Frankie. I congratulate you. I'm impressed every time, although I see you in person more than lecturing. But I'm so happy to be able to have an endodontist to refer to like Frankie. We work together, so you deserve all the applause you can get here. Let me comment. So let's see if I would send this case to Frankie, okay? Or I would try to take the tooth out and just place an implant and make it fast for the patient. Maybe a few years ago I would do that. But since I met these guys from Penn, changed my way of thinking. Now if I look at a case like this, where I look first, I look at the interproximal height of bone. So if I extract a tooth like this, and I don't have interproximal height of bone, I know in the aesthetic zone that this is a compromised case. So what it means, I can never bring back the connection of the soft tissue of the adjacent tooth. We know that the soft tissue above the bone is connected to the adjacent tooth, and this will be a compromised case. So the best thing is to try to save the biology surrounding the tooth in this single tooth environment. And my first option to delay biological changes would be to send a case like this to Frankie so he can take care from an endodontic point of view. I don't worry so much about this complication if I would have a good interproximal height of bone, but in this case, to delay the biological changes, I would give him then the option to do what he has to do. Sam, any comments?
Thank you, Marius. Looking from strictly a endodontic standpoint, which is, can I just do turn the lights on? Which is the laser pointer? Oh, here we go. So, Francesco brought everything perfectly to my attention, but from an endodontic standpoint, if you go back even to Dr. Trope's studies about coronal seal versus a good endodontic apical seal, it's actually more critical, and these words coming from an endodontist, not a restorative, not a periodontist. You can have a perfect looking root canal, and if you have a poor coronal seal, if there's caries or leaky restoration, then within 3 months of exposure to saliva, the bacteria has been found actually will get all the way to the apex. So as Dr. Maggiore pointed out, I look at this endo, and I cannot do a better job on the root canal. It looks perfect radiographically, but with that coronal caries, I know that there's contamination. The tricky part to the retreatment, unless Francesco's doing it, I know that if I retreat this and I go to remove all the gutta percha, I'm going to remove all the gutta percha except that apical 1 or 2 millimeters. So I'm actually going to make it look worse when I do a retreatment, because I'm going to sever the gutta percha right here, and that little piece that is now attached to the root will now become floating out into space into the lesion. So most likely in my hands, it's going to be a retreatment and probably followed by a surgical case. So yes, I would wait some time, because maybe we get lucky and we get this to heal from just a retreatment, but then we run an additional risk of this piece of gutta percha becoming a foreign body out there, and we still need to go in surgically afterwards to do both.
Thanks, Sam. Okay, next question. Următoarea. Okay, so
Vă rugăm să votați.
Okay. Scott, stay around, maybe I need you. Okay, let me comment on this. So, this patient had several endo treatments, I think also retreatment, and I think you don't have all the information, slight mobility, and you see the tooth is extruding slightly. So, in the aesthetic zone, when we look and we have endo complication and no perio involvement, the aesthetic probability and also integration probability is very high. The question is, now let's go and comment. Okay, let's go, Frankie. You comment on the endo retreatment, endo surgery. He doesn't know, so you give me your opinion.
I don't know.
Yeah, so that's right. You know, it was easy because that was his case. Now he has to comment on mine. Let's fight a little bit.
There is any probing?
Yes, the probing is like 5 millimeters pocket, 5 to 6.
5 to 6,
Yeah.
that is deep. It is probably that there is an endoperio communication.
Distal it's 5 to 6 and mesial it's less.
It doesn't matter, mesial or distal. If there is an endoperio, it's an endoperio. So, for me, probably, if you make just retreatment, you are not able to resolve. Here the problem is the perio. If the lesion is only endodontic lesion, means that there is a localized lesion in the apical part, but there is no probing, I can try to make probably surgery because the tooth was already surgerized. The tooth ends already in apicoectomy. So if I make only retreatment, it's probably not going to work. I would make directly a surgery. But if there is a probing, a deep probing of 5-6 millimeters, this means that there is already an endoperio communication. And if I make only an endodontic treatment, I'm not going to solve the endoperio lesion. This means that I create a chronic infection. So as soon as I took this tooth out, it's the better.
Okay, so if we look, how can we decide if we do late or immediate? Is it a difference in the final outcome? Scott, give me a comment on that so you see the specialist here. I think it makes it more interesting to have all specialties here getting involved.
Well, before I would even comment on immediate or late, I don't think that that's enough information for me yet. I would be doing certainly a cone beam CT in order for me to be able to visualize exactly what the extent of the lesion is, and then I can answer that question. Because at the moment, we don't know if the palatal bone is intact, we're not sure if the facial bone is intact, and we don't know if there's any kind of infiltration into the floor of the nose based upon that X-ray. So I would say, the other thing that you will see later this afternoon is that when you look at a periapical X-ray like you're seeing right there, that you don't have, you don't know what's happening right here. In this area above the apex of this tooth, there could be a huge concavity in that area. And therefore you extract the tooth and think that you're placing it into solid bone and you're perforating through the facial plate. And I'll probably demonstrate that a little bit later.
So Sam, is this on?
So I would like Dr. Gans to follow up with the cone beam comment about both scenarios. So let us know how that would change your treatment plan if there were no palatal bone, or what I'll do from both sides. That's question number one. My next question is to Marius. As a person who hasn't done a restoration since 1989, I'm scared because I see a central incisor that is a natural tooth with a lingual composite. So, provided that this tooth has to be extracted and you need to have some kind of an implant supported restoration, how are you going to match a single front tooth aesthetically, or are you now going to have to think ahead and maybe put porcelain veneers on adjacent teeth, or even would a 3-unit bridge be more aesthetic? So questions for both of the restorative docs.
Okay, so the decision tree for me when I do, let's suppose that we decided to extract this, probably the buccal plate will be resorbed and will need restoration. But the probing tells me that the soft tissue will collapse. That's why the probing, what Frankie asked, the soft tissue height is important. And we know after extraction that we have a bone resorption of 1 millimeter is followed by 2 millimeters of soft tissue recession. And then even if the prosthodontist can match the color, let's say with a good lab technician, you're still gonna miss the soft tissue frame. So in this case, an immediate implant would support the soft tissue from the beginning and gives you the opportunity to graft the buccal plate. So this is a very tricky, complicated case. So what I would decide, according to the endo-perio involvement and of the prosthetic thinking, I will do an immediate implant with immediate restoration to support the soft tissue. Okay. The aesthetic of the adjacent teeth is, if you support the soft tissue immediately, you don't harm the aesthetic of the neighboring teeth. Okay. The color is a prosthodontist. That's the lab technician. That's a lab technician. Okay. So in this case, when you have the perio involvement, I will do an extraction implant and graft the buccal plate. If we do it late, we are losing the anatomy. So in this case, you could go for a retreatment or an endo treatment first, but in this case, you can make it predictable. So, from my opinion, this would be an immediate implant case because the interproximal hydrophone involvement. Okay.
Wait, can Scott comment about the cone beam results, please?
Okay, I would actually disagree with Marius, which I like to do.
That's good.
Because again, I don't have enough information. If I had, I wasn't going to show a case like that, but I can show one a little bit later, which is almost identical to this one, which, looking at a periapical x-ray, you would say, yeah, no problem, we can do an immediate implant. That would be my first choice. I agree with Marius, it's my first choice. But if the bone isn't there, I'm not going to risk that whole area blowing out if that implant fails. So I'm going to extract, I'm going to graft, and I'm going to come back later in about 5-6 months and then place an implant, based upon the cone beam CT evaluation.
Yeah, that's how this works. In case of doubt, go conservative. Okay, that's our rule. In case of doubt, go conservative.
Putem afișa întrebarea 3?
So it's not only Maggiore and Steigmann, it's Maggiore, Steigmann, and friends, right? Like Pavarotti and friends, it's Maggiore and friends. Yeah. Okay, so, Frankie.
So, we go for the next case.
Wait.
Wait.
For them to vote.
No, I wanted to give some preliminary information in order to make it
tips and tricks or some hints?
No, just to describe the case. Okay. So there is a patient, is a man that has this root canal done a few years before. There is a casted post crown. The crown is intact, aesthetically it's very nice, and there is no leakage here. The margins are still fitting, are very good. It looks like there is no probing. The probings are within the normal limit, 2, maximum 3 millimeters, and there is a lesion that is localized in the apical part. There is a root canal filling, looks maybe a little short, and the patient has symptoms because there's a pain on palpation, on percussion, and there is no fistula, there is no swelling. So there are symptoms without fistula, without swelling, and radiographic appearance of periapical issues. No mobility, no problems. I'd like your comment.
Okay, so I don't know. You know, my opinion, if I see a post cemented in the root, I would, you know, because we work together, I wouldn't send the patient to Frankie. I would extract. You know, because that's if I need winter tires. No. But the thing is, I would send it to Frankie for a surgery.
If this was, let's say, your daughter,
Yes,
what would you do?
No, I would try to preserve, like I said, to delay, since if I were to delay the biological changes, I would refer to you and would ask you for a surgery. No, whenever I see a post...
Did you just change? You just changed the treatment.
No. Said not for retreatment. I wouldn't send it to you for retreatment. Okay. I would send it for surgery. When I see a post in a tooth, I always worry about the trauma and the fragility.
Okay.
So if I would, retreatment would not be my choice. My choice would be an implant instead of retreatment, but another choice would be endosurgery.
Okay.
It's good. I don't know his cases, and he doesn't know mine, so we make it very
blind, double blind.
I think what's interesting is that if it was my daughter, I would send to Dr. Maggiore for apical surgery. If it was my mother-in-law, I would send to Marius for immediate extraction.
Okay. So, give them the answer. Scott,
Like Scott comment.
I can't do better than that.
No, because you don't know his mother-in-law.
Okay. Here, again, this location, position in terms of implants, aesthetics, is pretty critical. Okay, we have a very good possibility of putting an implant, but how if we resect just the apical part and we make a 3mm filling? This part is very easy to clean. Normally, when we make endomicrosurgery, we resect the 3mm and other 3mm, they are cleaned by ultrasonic. This means at least 3mm. This means that for sure all the apical part can be cleaned. So for me, this would be for sure the first approach, since the crown is nice, the patient wants a pretty conservative approach. I don't see the reason why I should run into extraction, implant, risk of, I don't know, aesthetic problems afterwards, if I have already a nice aesthetic at this moment. And in one visit, that is the surgical appointment, I would solve the problem for me.
Can I make a quick comment? My only, from a prosthetic point of view and not from an implant point of view, is that if you look at that periapical x-ray, you can see that that post is pretty wide in relationship to the actual width of the root itself. And secondly, you can see that there is some bone loss, or there is some, from the margin of the crown to the height of the bone, there is a distance there, which may or may not mean that the crown is engaging the actual tooth itself, creating a ferrule effect to strengthen that relationship. Because there is a high risk, in my opinion, that this may fracture down the road. Now, if there's no other symptoms, then certainly the surgical approach would be an excellent approach. But I should caution, from a prosthetic point of view, that when we're creating this type of restoration, that we want to grab as much of the clinical crown as possible to be able to kind of stress shield that root from fracture.
Just a quick question, probably not indicated in this case, but I'm just curious from either Marius or Scott, would you consider cases where you would know that you're planning a future implant, and instead of immediately extracting the tooth, maybe put an orthoband and pull the tooth down to slowly extract it to bring that horizontal height of bone with you. In this case, no, with the crown and the post and everything, but other cases, I don't know whether we'll see today or not, would you consider orthodontically extruding the tooth, therefore slowly extracting it to bring the horizontal bone down, and then you can do an extraction and immediate implant?
Yeah, well, this particular case I don't think would fall for it, only because if you take a look at the interproximal heights of bone, based upon the periapical x-ray without combing, they look very good. And so the only time I would try to recommend to do orthodontic extrusion would be if the interproximal height of bone is compromised. Marius?
Yeah, but even though today we know that after orthodontic extrusion we might have some drawback. Because what you do when you orthodontically extrude the tooth, you bring down the periodontium of this tooth. And after extraction, what keeps the soft tissue is the periodontium of the neighboring teeth. So if you have a resorption after extraction of this bone, it doesn't help because the soft tissue and the papilla are always belong to the neighboring tooth. So what you can do, or what makes sense, if you orthodontically extrude the neighboring teeth with it. So that's the clue. So when we have multiple adjacent teeth, we do that. Some people, what they do is they leave a root canal treated root under the soft tissue to maintain the color. But orthodontic extrusion of a single tooth sometimes is questionable today. It was fashionable in the past. Okay. Commentary in the salon? No? I said any comments from the... Okay. Okay. Yeah. So, next.
Give the ball. The answer or?
Yeah. You are.
So
You're okay.
My approach here is, again, aesthetically it's good. Patient besides this lesion and localized symptoms is fine. So my approach was just to make endodontic microsurgery. And probably I did not even graft here because the lesion was not that big that it was required.
Putem affișa următoarea întrebare, vă rog?
The image is a little bit distorted. Okay. Now, yeah, it's a little bit distorted. But what you can see here is that we have a big resorption of the interproximal bone. And we have an endodontic treated tooth, but in the midline, you are missing 10 millimeters of vertical bone due to trauma, or it could be previously orthodontic treatment in the young years. This is a special case. This is a wife of a Nobel Prize winner for medicine from Heidelberg. So that's a big thing. The question is, if we look only at the endo, should we do the endo treatment? Should we extract? But if we extract, what will happen with the soft tissue and in the aesthetic zone in a patient with a high smile line when there is no interproximal bone and we should extract this tooth? Should we, again, place the implant late, graft vertically? Can we graft vertically predictably or place an implant?
Is that connected to the molar and the, is that connected?
No, this is a central. There are two centrals. I don't know why it's
Oh,
stretched.
okay.
Two centrals, this is 1, 1, 2, 1. And this
Yeah,
is the
I actually
midline.
thought it was
And they were connected because the tool started to be mobile. No. It's just composite. I don't know why it's stretched. No interproximal bone. Yeah.
So those are two centrals?
Two centrals. Yeah. You see the tooth, 2, 1.
I have a feeling I know which,
It's a 9.
which geographical area.
Yeah,
it came
yeah.
from.
Yeah.
The South Africa.
No, it's not. It's Caucasian. Okay.
In North Africa, a large diastema is a sign of manliness.
So,
So it's
Frankie,
North-
no comment?
it's
No,
North
no,
Africa.
Caucasian, not
I have no
Caucasian.
idea what I'm going to do here.
So what are you going to do here? There's no
I don't know.
interproximal, now it's
You are asking to the wrong, I would refer to implantologist.
Okay. Scott?
It's not an endo case, it's very simple.
Okay, in a situation like this, oftentimes, again, beyond the apex of both of those central incisors, beyond the apex of those roots, is usually a very steep concavity. I would be very surprised if there was really a lot of bone above the apex of those roots. So I would say that without, of course, without a cone beam CT image, you really can't say whether you can extract and put implants in there. But there's one other anatomical reality that we have to consider, and that is the width of the incisive canal, which is between those central incisors somewhere. So definitely, I would want to do more imaging to be able to get the best answer.
Yeah. From a aesthetic point of view, this is one of the most challenging cases because we know from Tarno's paper, maybe the most quoted paper, that the soft tissue height or the papilla is when the distance from the contact point to the interproximal height of bone is 5 millimeters. In this case, the distance is 12 millimeters. So the question is, what will happen? And can we regain the soft tissue? This would be maybe a case of orthodontic extrusion. The question is, can you bring the bone between the two central incisors down with orthodontic extrusion?
Well,
So this is a very difficult case.
Yeah, depending upon the smile line as well,
Yeah.
you would make an evaluation. But what's interesting here is also depending upon whether you have volume of bone. If you can imagine on the right side or the left central, if you see that there is an interproximal height of bone, although I don't know what that black line is there, but there is interproximal height of bone in that area. So if you could, in fact, place let's say a platform switch implant or an implant of specific design that would be approximately at the mesial aspect of where that interproximal height of bone is, and graft at the same time, and place a healing collar that is a tapered healing collar that would help support that tissue, you may still be able to get a very aesthetic result placing 1 or 2 implants to 2 centrals and extracting them.
You know, the amazing thing, I agree with you. We agree to disagree. Yeah, so in this case, when you see that the soft tissue will not have a support, you may be fooled by the endo, but you have to place an implant immediately and support the surrounding soft tissue, because we all know that in a single tooth environment, to grow the bone vertically is very less predictable. Okay.
Întrebarea numărul 5.
So it's the correct answer. Wow.
No, I think this was one of the resonance cases that was shown earlier this morning.
Looks like we have so many of these cases.
Yeah. This to me, I'm not sure what that line is up there. Do you know what that is?
Gutta percha, overfilling gutta percha.
That's gutta percha?
Yes.
Okay.
No, this is gutta percha into the lesion. This tooth, no, it's not a fistula. These two, the central incisor, have been retreated, and during the retreatment, obturation material went into the lesion. Then they removed the gutta percha material from the canal, but they were not able to remove gutta percha material that was already into the lesion. So there is a lesion. Number this is number 8, right? Number 8 is open because the retreatment was started, and number 7, that is the lateral, is a vital tooth.
So this is in the middle of a retreatment? So
It's
we're
in the middle of
assuming
the retreatment.
That's calcium hydroxide maybe?
Yeah, there is a medication probably inside the canal.
Okay. I've never seen this case before, but my comment is you have to do a cone beam. I'm going to save Scott the problem of saying that, because when I see a lesion this dark, I need to know whether it's buccal or palatal or through and through lesion, which would alter my potential treatment planning. So
So if it's on the buckle of the facial, what would your treatment plan be?
It's only buckle.
It's only buckle?
This is similar to the case that I showed this morning.
There's a big difference here, though, and that is that it appears, well, first of all, this is near the floor of the nose and not the maxillary sinus, and second of all, it appears that the bone above that area is intact. If it was only on the facial plate, then you might have, a different concept. And so,
No, I had a case that there was a central and lateral incisor.
Oh, this is
also.
I thought you were talking about the one with
different.
the
No, not with the sinus. No. So first of all, the cone beam would show. Okay, so if we're assuming that it's buccal, at least it makes the approach easier. I would obviously complete the root canal retreatment of the central incisor. I would prophylactically treat the lateral incisor, because even if there is blood flow or nerve supply now, there won't be once we go in surgically, and then I have to go in surgically and remove a lesion like this. There's no way of removing that excess gutta percha from a conventional standpoint. If it was a through and through lesion, then we probably have to raise both a buccal and a palatal flap, and as I showed this morning, graft it with 2 membranes, possibly.
No, I am happy about this number.
Yeah. So that's the right answer, right?
Yeah.
Oh, but if you let me ask Sam and Frankie one question. Okay, let's see, one of them has to be compromised. Okay. So,
which way? Structure.
yeah. So you do the retreatment and surgical endo retreatment, non-surgical first. But if you have to take one, which one would you try to save if there is no other way? You would try to save both. I'll tell you why.
I will try to save the one that has the highest
Yeah.
crystal bone.
That was my question. That's the highest interproximal bone, because that will maintain the height. Okay. So when we think about, and I send patients for endo to Frankie, and we communicate. Sometimes I have a preference, and I always say, hey, try to save both, but just in case, okay, try harder on this one. People ask me, how many times should you do apicoectomy? 3 times, 5 times is enough? And sometimes I say, when I have 2 adjacent teeth in the aesthetic zone, you can do it 100 times, because if you don't save one of the 2 teeth, you might end up with a terrible result here. Any comments on that, Scott?
Yeah, well, the saving grace here is the fact that you have bone. You have interproximal height of bone both on the mesial and the distal of both of those teeth. And that, to me, is the most critical part of what we're seeing without any further imaging.
The worst would be to extract both teeth. That would be terrible.
I mean, the concept here, we have a clear endodontic lesion.
Yeah.
It's a big, but it's a pure, only endodontic lesion. There is no probing. So, if we are able to clean the canal, and if we are able to remove to clean the lesion and to create an apical plug here, and eventually we need augmentation procedure, probably yes, it's fine. So we can maintain both teeth as far as we can. I don't know, probably now and not, but at least we can save the aesthetics until situation change. And it is correct that we need, even though this tooth is vital, when we do surgery, we are going to remove the vascularization and the denervation of this tooth. So this tooth has to be treated endodontically before the surgery. So we make both non-surgical treatment and then afterwards surgical retreatment.
Okay.
Pentru ce la ultima întrebare?
I'm curious if the votes would be the same if we did this questionnaire before Dr. Kretschmann and Frankie's lecture, because they showed so much success in endosurgery that it's obvious that now everybody's voting for oral surgery. We should have done it before and after.
And after,
yeah.
yes.
So, but it was, after the party. Okay. So again, this is a case. I can give you some details. Again, the tooth 1-1 is mobile. It's a periodontal problem. And the question is, endo and perio treatment, can we try to do the endo first and then try to save the tooth as long as possible? Or should we place an implant immediately or late? As you can see, the tooth is mobile because it's moving from its initial position. So that's why the question is very obvious. Can you refer and try to save it or extract and place an implant? Perio treatment means just classical perio treatment. You cannot do surgical perio treatment because if you do surgical perio treatment, you will lose the soft tissue height and you will expose the teeth, and then it will be followed by recession. Scaling and root planing. Okay, endo, scaling and root planing, or implant immediately. And the question was if we put any myelocycline or some gels inside this. Yes, there is some data in the literature. We're using it, but only we don't have such a high pocket. If it's so deep, we know from perio that after 7 millimeters of depth, the pathogenicity of the pocket is changing. So if you put something inside, it will change for a short time, but then you're going to have the same pathogens. So you have to reduce the pocket to at least 5 millimeters. If it's more than that, it can give complications. Scott?
Yeah, well, first of all, I agree, but I also have to raise a flag of caution about immediate implant placement without getting additional information, because again, the apex of that root, or the apex of both of those roots, with the periapical X-ray, you really can't tell what's going on beyond that and above that. And so therefore, I would be a little bit concerned, as well as where the incisive canal is in relationship to that root and the path that you want to take with your implant.
So what you can see here, that in endo, we can tell much more with X-rays. But if you talk about aesthetics and perio and implants, the additional information is much more needed, I think, than in endo alone, or not.
Now, I'm going to ask the question of the 36.4% of the audience who's saying endo-perio treatment, because so far all I have heard is that this is a periodontally compromised tooth. The periapical bone seems to be intact, and I'm assuming that this would respond to cold. I'm assuming this would respond to an electric pulp test. So why do the endodontic treatment? Is anybody from the audience who is brave enough to comment on the 36.4% why we would do endodontic treatment in addition to the periodontal treatment?
Prophylactic.
Who?
Prophylactic.
You make prophylactic.
They prevent with the endo.
Let's make prophylactic also this time.
Yeah. Okay. Good. So now we're going to do a small presentation to conclude all these questions.
What's the right answer?
Oh, the right answer is immediate implant in this case, to preserve it.
To preserve the
Yes.
soft tissue.
The problem is what you cannot see here again with periapical X-ray is that you don't know how the soft tissue will behave. Even if you have a perforation and no buccal plate, the soft tissue again collapsing at this level cannot be brought back. So if you go only for osseointegration, you could go for late implant. If you go for aesthetics, as we are at the aesthetic meeting, that will be very difficult to bring the bone back and the soft tissue in the height, especially when you have a diastema.
Yeah, we're not seeing what the soft tissue looks like, which is going to be very important to make some of these decisions. And there also looks like there's an impacted tooth there, which may cause some concern in the future in terms of what would happen in case the other central starts to go.
My question for either Marius or Scott. Marius, correct me if I'm wrong, but I know you've told me when you extract a tooth like this, you'll get a good bone fill in the socket apically, because right now there's buccal bone. But let's just assume that there's buccal bone loss. If you look at that, you're always going to have a concavity, correct? So my concern would be placing an implant, the threads of the implant would be embedded in bone here. Am I correct in saying that the implant would never fully integrate in the coronal aspect? Would there always be exposed threads of that implant, and is that a problem?
Yeah, well, first of all, it depends upon what implant system that you're using and what your philosophy is in terms of how deep you want to place the implant. So when you, again, without all the information that we have, I'll be talking later about volume of bone. And I believe that when we're placing implants, we need a volume of bone to surround the implant. And of course, from a periapical X-ray like this, we don't know that, what kind of volume of bone. So to purposely expose threads, can we do that? Yes. But I would, if we wanted to do that, we would probably want to graft at the same time, not to support the implant, but to support the tissue. Or we may place a healing collar at the same time the implant is placed, again to support the tissue and to support the bone graft, and then we can try to rebuild and maintain the gingival architecture. And by the way, there's one other point. Of course, this is another diastema case, which may create other aesthetic problems.
So it's very complex. What we have to understand that if we extract a tooth and we try to do socket preservation and fill in some bone graft, the socket preservation only goes as high as the interproximal peak of bone. You can never graft. You can maintain the buccal bone here, but as high as you can go is always the interproximal peak. So that's why what Scott said, it's depending on the implant system you use, because today you have implant systems which you can place above the bone to support the soft tissue. It doesn't have to be buried in the bone.
So now I have to change my whole lecture. You have to give me some time.
Okay. Okay, so we have to switch now to the beamer.